The broadcast is now starting. All attendees are in listen-only mode.
Greetings to everybody. You are welcome to today's ISQua webinar on changing the paradigm of patient safety, resilient healthcare. I'm absolutely honored to introduce today's presenters. We have two presenters today, Professor Jeffrey Braithwaite and Dr. Robyn Clay-Williams. I'll just shortly introduce each of them. Professor Jeffrey Braithwaite is the Foundation Director of Australian Institute of Health Innovation, Director of Centre for Clinical Governance Research and Professor of Health System Research, Faculty of Medicine, University of South Wales, Australia. His research examines the changing nature of health systems, particularly patient safety standards and accreditation, leadership and management, the structure and culture of organization and their network characteristics, attracting funding of more than 59 million Australian dollars, which is equivalent to 40 million euros or 33 million of British pounds. Professor Braithwaite has published extensively with more than 500 publications in total, and he has presented at international and national conferences on more than 500 occasions, including 60 keynote addresses. His research appears in journals such as British Medical Journal, The Lancet, Social Science and Medicine, BMJ Quality and Safety, International Journal of Quality in Healthcare, Journal of Managerial Psychology, as well as Journal of the Medical Informatics Association and many other prestigious journals. Professor Braithwaite has received numerous national and international awards for his teaching and research. So his co-presenter today is Dr. Robyn Clay-Williams. Robyn Clay-Williams is formerly a military test pilot and an electronics engineer, as well as a flight instructor. As the postdoctoral fellow, Robyn conducts health services research in the field of human practice in healthcare. Current projects include applying engineering resilience to healthcare to improve patient safety, system dynamics modeling of healthcare system and processes, usability of medical devices and IT systems, and analysis of behavioral of healthcare professionals. Robyn has just returned from 2 months working in Denmark with Professor Erik Honegal on engineering resilience principles. Just to remind you that Professors Braithwaite and Dr. Robyn Clay-Williams' presentation will take approximately 45 minutes today, and we will leave 10-15 minutes at the end for any questions that you may have. Please type your questions in the question or chat box provided, and they will be posted to either Professor Braithwaite or Dr. Robyn Clay-Williams at the end of this session. Enjoy the presentation, and over to you, Jeffrey and Robyn.
Thank you very much, Juliana. So, colleagues and friends across the world, welcome to this presentation. We've been thinking a lot about patient safety here in Sydney, but also with our colleagues across the world in different countries, especially Europe and North America, and in various countries where people are starting to worry and wonder, really, why haven't we gotten better results? Why haven't we gone further with making care safer for patients? So we're in the middle of publishing a series of books, especially with Erik Honegal, Professor Erik Honegal in Denmark, and Professor Bob Weers in Florida in the United States. And Robyn and I have been part of that group to look at how can we go further with patient safety and how can we think differently about it. We have one book already published, we have another that's in press, and a third one in production. The classic thing with academics is once they get on an idea and start writing, then books and papers start to appear. And we're going to summarize some of our thinking and the thinking of some of our colleagues across the world on this idea of, can we change the paradigm of patient safety? We call this resilient healthcare. Can we make the health system more resilient? So allow me to process us through some slides to make that case and help you and us to consider together how we might prosecute this idea of, can we make healthcare more resilient, and where is it already naturally resilient? So as Juliana said, and thank you for that very generous introduction, Juliana, I'll get you to introduce me every time I've got to make a talk. That was such a generous introduction. We're from the Australian Institute of Health Innovation at Macquarie University, and we do health systems research. I like to joke, and some of you might have heard me say this, that we don't splice genes, we don't cure cancer. We do something much, much more important and something much, much more complex. We try and work on researching the health system, and with our insights and our research evidence, try to find new ways to improve it. And that's kind of my, if you like, my lifelong ambition. How can we help as researchers to research the health system and improve it, and not just the Australian health system, across the world? So we have 3 centres. We have my own centre. I'm the foundation director of the Institute, but also I run a centre. It used to be called the Centre for Clinical Governance Research, and now it's called the Centre for Healthcare Resilience and Implementation Science. Enrico Cuero, who many of you might know, is Professor of Health Informatics, and he runs a centre within our institute, the Centre for Health Informatics. And Joanna Westbrook, she's an epidemiologist, and she runs the Centre for Health Systems and Safety Research. And why I am focusing on that just at the start of the talk is to let you know that we produce maybe 150 papers, maybe 200 papers a year. There's about 100 of us working in this enterprise in our institute, and we publish regularly a bulletin of our recent papers. So if you want to tap into us, if you want to work with us, do research with us, share ideas, see us at conferences, but by all means send us an email, and we can talk not just about resilient healthcare, but other things. So enough about that. Let's get on with the presentation itself. So you've got to start talks like this with a snappy quote, don't you? Usually from Einstein or Shakespeare or something like that. So the snappy quote I'd like to introduce you to is, after decades of improving the healthcare system, patients still receive care that's highly variable, frequently inappropriate, and too often unsafe. Now, it's with humility that I have to say I helped write that. That's one of my quotes. So, you know, academics can get a bit egocentric. But I say that to start the talk because I think that's very important. Because if you think about it, we've been trying worldwide to tackle patient safety for, well, more than 2 decades. The earlier studies are 25 years old now. A Harvard Medical Practice study, for example. And yet, we are still unsatisfied and still uncomfortable that care delivered to patients, quite a lot of it, a proportion of it, is unsafe. So we think that's a very serious question, and it sends alarm bells ringing, suggesting to us, should we keep on doing the same thing over and over again and expecting different results? Or do we need some more strings to our bow? Do we need to be doing things differently? Do we in fact need a paradigm shift in the way we think about patient safety? So that's the proposition that Robyn and I want to put to you. So let's talk a bit further about that. Before I go on, though, maybe, Robyn, is this the right pitch? Are we sort of, do we have anything else to say?
Oh, I think if we can address the patient safety, like, because we are finding that only, 55% of people receive the appropriate care. If we can address that problem, then I think we can make a big difference. So.
Okay, well, the audience is going to see if we make our case well enough. Okay. So let me take you, having established that as a significant problem, and we're hoping you agree that that's certainly most people across the world agree. Let me take you to maybe a different starting point, just to prosecute our argument. Let me ask you this question. How do organizations work? Just reflect on that for a moment. How do organizations work? And I guess when we ask that question, most people would think, well, how does my organization work, or those organizations that I know or I've been in as a clinician, as a manager, as a policymaker, as a patient? So I guess when you ask a question like that of people, the immediate thing is, in the mental model that people have, that they use to answer questions like that, they often see an organization structure. So how do organizations work? Well, they get income, they get resources, they have people, and they get organized into a structure. And all of us have seen countless organization charts where the CEO is at the top, and then there's layers of management or clinician managers in our case, and then there's people on the front line, people who we say are at the sharp end of healthcare, delivering care to patients. Now that's a very cause and effect linear model. And if you have that kind of thought in your brain that that's the way organizations work, that's the way the world works, then you'll tend to see error and patient safety and adverse events as linear too, because the cognitive architecture that you have sees the world in structured sort of ways. So if you have that in your head, then you'll see errors in terms of the domino effect. That's been written about since 1931. You'll see errors and adverse events and problems that you face, and you'll say, I better do a root cause analysis to find out what is the root cause of the problem that I'm faced with. And it takes you to somewhere like Jim Reason's famous Swiss cheese example, where somehow an error will find its way through the holes in the slices of cheese, and somehow the error will find its way through the complex system and manifest as an error. So that's logical cause-effect type thinking, and all of us do that at some of the time, and many of us do it. That's our major way of thinking. So we then can see that that leads naturally to the stories that we tell ourselves when errors occur. So here's a medication error story in this slide. There's a nurse staffing problem. There aren't enough nurses. Almost every system goes through phases and perhaps always has problems of that. The fax system for ordering medications is broken. The tube system for obtaining medications is broken, perhaps. The nurse borrows medication from another patient. The nurse gives the patient a medication. That patient has an allergic reaction. The patient arrests and dies. Now, uncomfortably, while you're listening to me, that's happening somewhere in a hospital in a rich country, and goodness knows, because we don't do enough research on it, what's happening in a poorer health system or a low or middle income health system. Nevertheless, that's a common way that we conceptualize the problem of patient safety, and we've got many of those. So, okay, I get that, you get that. What are we doing in response? Well, we've thrown a lot at this. There's an English phrase that says we've thrown the kitchen sink at this problem. I hope that translates into your world. But what it means is we've done an awful lot in response when we started to recognize the patient safety problem about 25 years ago. So we've done safety training and medical emergency teams and rapid response systems, root cause analysis, incident monitoring, regulation, accreditation. ISQua, of course, is very, very prominent in accreditation. Credentialing, standards, policies, guidelines, clinical guidelines, procedures and checklists from WHO and Al Gawandhi's work and Haynes's work. Restructuring the health system or part of it. Having inquiries when things go wrong. For example, Britain seems to export and be very, very prominent in inquiries. And we've tried harder and we've hoped. And you can insert your favored strategy here in the last bullet point, because there'll be many that I haven't covered. This is just my, Robyn and my sort of quick glance at the sort of things we're doing in response. One of the things I would draw to your attention, though, is those tend to be quite linear too. They sort of are predicated on an idea that says, if we do these, then we will sort out patient safety and we will make care safer for patients. However, a flaw in that logic is, to be frank, healthcare really looks like this. It doesn't really look like the organization chart that many of us had in our heads when I said, what's your model for an organization?
And that's just, that thing that you're looking at the moment is just some of the links in a single emergency department, to give you a feel for how complex our systems are.
So in the jargon, and you know this because we've all been to ISQua conferences or other sort of sessions where we've thought about this, in the jargon, healthcare is a complex adaptive system. It's very, very complex and complicated. There's lots of connections and stuff that an organization chart or a linear view doesn't capture. It's adaptive in that regardless of management policy maker effort, it seems to adapt itself almost of its own free will. And it's a system by which we mean it's linked up, the parts are linked, although sometimes there's less integrated care than we'd like.
So much more like a biological system than a technical system in many ways.
Sure, and that's a good point, Robyn. What we're really trying to say is let's differentiate healthcare as a technical system from healthcare as a complex adaptive system.
Yeah.
because whichever model we have in our minds, it'll draw us to the kinds of strategies that we need to solve the problem of patient safety. So other research we've done shows, and this is another emergency department, where we said, well, what's the network of clinicians that deliver care? And these are just in the slides, for example. You can have a copy of these slides. This shows nurses are blue, doctors are red, allied health are green, yellow, and admin and support are green. And when we said to people, 105 people in this emergency department, who would you go to solve a problem? And we created a network diagram of who they would go to. We found that everybody clustered together in their tribes. So who would you go to if you're a nurse and you have a problem? Another nurse. Who would you go to if you're a red dot doctor and you have a problem? Another doctor, and so on and so forth. So the other thing we want to say is not only is healthcare a complex adaptive system, not only is it complicated, it's tribal. And yet we're told that what we need to do to create safer care is have multidisciplinary teams. Well, this is only one emergency department, but we've got other research to show that healthcare clusters in tribes rather than does genuine multidisciplinary teamwork many times, perhaps most times. And so here's some other diagrams in this study. You can have a copy if you like. It's from Creswick et al. With Joanna Westbrook and myself in 2009 in BMC Health Services Research Open Access. But if you want a copy to look at this particular angle that we're taking, happy to share them with you. So we've come to a conclusion. We've come to a conclusion along with Holnagel and Weers and other people across the world. And Robyn and I are part of a resilient healthcare net to think about this. We've come to a conclusion that, you know, we've tried so hard with patient safety, no one's doubting the genuine attempts we've made, but we haven't gone as far as we'd like, so we need new ways of thinking, a paradigm shift. And especially, we'd like to say, we need to go beyond just linear reductionism where we say, oh, this causes this, because that's not sophisticated enough in the complex systems that we currently work in. So, Robyn, I wonder if you'd take up the story from here.
Yeah, so what we find at the moment is that we tend to look at things in terms of our typical understanding of the safety is finding things in terms of finding and fixing. Now, coming from aviation, things that go wrong are very, very visible, and they're becoming increasingly so in healthcare. So if you've got, you know, a death or that's occurred in your organisation as a result of an adverse event or disability, then that's going to be the visible thing, and that's going to be the thing that you want to find and then fix. So the way we've looked at it in the past is let's just tackle the things that go wrong. So because we put all our energy and all our time into addressing what's gone wrong, we have very little left over to look at what's actually going right in an organisation. And part of the problem with this is that it's the same processes that cause things to go wrong and things to go right. So when people come to work each day, they don't come in thinking, I'm going to use this process where things are going to go wrong. They work the same way each day, but because of variability in their performance, sometimes things go better than others. So all of us will have a good day where everything goes right, or a bad day where things go wrong. And if you've got multiple people in an organisation, particularly a complex organisation like healthcare, you can get multiple interaction of people having a bad day, and that's where you can get some really serious adverse events. So by tackling things that go wrong, we're not really necessarily able to address it. So, and there's little demand from authorities and regulators looking at what does work well. Really, we're very much concentrating on the visible, which is when things go wrong. So what we term this perspective that we've been using up to now as safety one perspective. So that's a perspective where generally things do go right, but every now and then we'll get an adverse event. And the way we deal with that is we're reactive. So we then come in and go, oh, there's an adverse event. I need to do something to fix that and to stop it happening again. And it assumes that safety can be achieved by finding and fixing these adverse events. So over time, if we can find all the things that go wrong and put things in place to make sure they don't ever go wrong again, we can, in theory, have 100% safety. Well, we know that doesn't work. And even in places like aviation, there will always be a certain percentage of things that go wrong. So the new perspective we're looking at, we're terming a safety two perspective. And this is a recognition that that it's the same process that causes things to go wrong as go right. So what we really want to do is we want to be able to succeed as much as possible under varying conditions. So this is a much more proactive approach where we're having a look ahead of time to see, well, how can we improve the number of things that go right? And because we're using the same processes, if we can focus on what goes right and what it is that causes that to go right, we can make more things go right and therefore, in theory, have less adverse events. So it's a different perspective. It's a different way of looking at safety. However, we don't have to throw our old techniques away. A lot of the techniques that we've used for safety 1 can still be used for safety 2. They just might need some adaptation. And it allows us to look at things that go right and analyse why they work well and use that knowledge to then improve our processes across our system. What it does require, though, is it requires proactive management. And what we're trying to do is we're trying to reduce the variability, because it's the variability, particularly at that lower end, that is going to cause more adverse events. So what if we changed our definition of safety? What if we looked at our idea of safety as, rather than avoiding something that goes wrong, ensuring everything goes right? Because it's pretty difficult to avoid something going wrong. When we come in, we're not going to know ahead of time what it is that goes wrong. If we knew, it wouldn't happen. So we can spend a lot of energy trying to avoid these things that we could otherwise be spending on trying to make sure that things go right. So the new focus that we're looking at is trying to find ways of ensuring that the maximum number of things go right. And in order to do that, we need to have a better understanding of how things happen in the healthcare system. How do things happen on a day-to-day basis? How do we get this variability? And how do we reduce the variability so that we can get more things going right?
So let's explore that. We've got the main sort of thrust of what we're saying, but let's explore that in more detail. So if you think about it, and I don't want to be disparaging to all the work that's gone on in the past to find and fix errors and try and reduce them, but in a way it would be like barnyard chickens, pecking, finding errors and then trying to fix them. And what perhaps we haven't looked at is the bigger picture of healthcare is the 100% of things that go that happen, 90% of those go right. Now, in a complex adaptive system, that's pretty amazing. It might be not so much that we should worry about 10% that goes wrong, but marvel at the fact that we manage to produce so much good care. Normal, everyday clinical activities produce good care. And we need to really understand that. We really need to focus on that good care, the 90%, and say to ourselves, how come in this complex adaptive system with not enough resources and no staffing problems and aging workforce and lots of demand from patients, how come we manage to get so many things right so often? And then should we not study that and understand it? Because we never study it. We take for granted the 90% is what the health system should do. We never study it. That's amazing. As a researcher, surely I should be just studying the whole of healthcare, not just where errors occur.
Such a bigger database if you're looking at everything. Rather than a small percentage, because we do find in adverse events in healthcare it is quite difficult because there are so few to actually get good information out of it.
Especially in some specific categories, yes. So let's just think about that, just dwell on that for a little while. So harm in acute settings. Across time, what we've surmised from a number of studies across the world, unfortunately they're almost all in OECD-style developed countries, and we need to do much more work in developing countries. But harm, roughly in acute settings, runs at about 10% or so. So 10% of admissions get some sort of harm. We know what they are. They're classically an infection or a fall while in hospital or a medication error. And about a third, we think, across many studies, a third we deem to be preventable, perhaps a bit more. Some studies have actually said harm is more than 10% of cases, but it depends how you define harm or an adverse event. Nevertheless, that's a sizable problem, and we focused on below the line adverse events. So the question we've got is, well, what's here? What's in the above the line? Everyday work that somehow clinical teams manage to conspire together, even in toxic environments, even in environments where there aren't many resources, to get things right. And what we want to know is how come? What's in there? So let's just explore that for a bit. So we focused on the 10%, when things go wrong in the blue box. And what we've done is we've thrown inquiries, incident monitoring, root cause analysis, hand hygiene, handover checklists, etc., 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 at that problem. But we haven't looked at when things go right, the 90%, where healthcare is resilient. So why don't we have any theories about that? Why don't we do much work on that? Why don't we understand why it is that we succeed in so many cases? So we've been seduced by the 10% and spent most of our time there. I think in 10 years' time, Robyn and I think in 10 years' time, we might walk down the street and say, hey, you know, back in 2014, what on earth were we thinking? We had accumulated a lot of knowledge in 2014 about when things go wrong, but we made little progress. We knew little about things going right, where we succeed. And this everyday clinical behaviour, relying on the expertise of clinicians and tacit knowledge at the sharp end of the health system, at the clinical front line, creates safe, effective care more times than perhaps we could imagine. So we call this resilient healthcare, and we think we need to know more about it. We think we need to study it, and we need to think, if we could, to bottle it. Well, I'm not very good at bottling things. I'm an academic, so instead, with colleagues, I'm writing a series of books on this. So, in summary, we have a lot of resilience in every health system. We've just perhaps overlooked it, ignored it, neglected it in our rush to try and stamp out errors. We have a lot of natural resilience, and wherever we have resilience, we need to trade on that and develop more of it. So, Robyn, in summary, we want to say resilience is the capacity to bounce back, the capacity to maintain a system to function in the event of a disturbance like an adverse event or some other bigger problem, and the ability to withstand, recover from, and reorganize in response to crises.
So essentially it's the same sort of concept when you think of personal resilience, how you could have something happen to you, some adverse thing, and people can be resilient and they can cope with that and still get over it and manage to maintain their normal life. You get exactly the same concept for a team, you get it for a department, you can get it for an organisation, and you can have it for a system. And that's what we're talking about.
And Robyn, we're showing Eric Holnagel's famous definition. It's famous for us. I don't know. Some of you have seen this and some of you haven't, but it's his famous definition. Do you want to just sort of...
Okay, so what we're saying is a system's resilient if it can adjust its functioning prior to, during, or following an event, which basically means a change or disturbance in the system, and still continue to sustain required operations. So, and that's under both expected and unexpected conditions. So that's a definition that's very relevant to healthcare, with the number of unexpected things that we find happen and the amount of variability that we see in that system. So we've got, just to sort of talk a little bit more about why we have this difference between our understanding of what goes right and what goes wrong. One of the things that we find, particularly in healthcare, although it's applicable to many organisations, is a difference between work as imagined and work as done. So you've got people who are organising the workplace, perhaps management or administrators or leaders within the workplace, that have a view that work's accomplished in a certain way, and they'll have in their mind a mental model or procedures of how things are carried out. But what actually happens when you get down to the coalface, so the clinician's actually working with a patient, is they often find that these procedures just don't work. Either, they don't have enough time to do it the way it's written, or they don't have the resources to do it the way it's written, or there's sufficient variability in the patient condition that the way it's written just doesn't work for this patient, so they have to do something different. So you end up with this quite large gap between how people imagine work is done and how work actually has to be done to accomplish it. So we get lots of workarounds and things like that, just so that things can be accomplished. And the problem with this is that when we try and figure out solutions to fix problems in the work, is that the solutions are often figured out at the point where work is imagined rather than where work is done. So the solutions are often figured out by people like quality organisations or by management or leadership within the organisation. And they're figuring it out according to their mental model of what they think is happening. or in accordance with the procedures that they've directed. So if something's not working, they think, well, I'll just need to change the procedure. Whereas in reality, it's a change in work as done, not as work as imagined. So when we start looking at how do we solve the problems to have more success at the coalface, we need to start looking at solutions that work in regard to work as actually done, rather than work as you know, management or people at a high level think or intend that it be done. So I'm going to show you now just a technique that we've started using to try and have a look at how can you tell the difference between this work as imagined and work as done, and you know, how can you help fix that. So the thing that I'm going to talk about, and I'll just give an example, is a thing called functional residence analysis method. So that was developed by Eric Holnagel and colleagues, and it was actually developed initially as part of an adverse event analysis tool. But now we're starting to use it to try and identify differences between work as done and work as imagined down at the coalface. So the example I'm going to give you today is to do with clinical guidelines or protocols. And we know that clinical guidelines and protocols are not generally followed, that uptake is really quite poor once we try and implement them in the system. For example, as few as 24% of ICU or intensive care unit patients receive the full recommended care. And people think the literature at the moment is saying, well, it's compliance. You know, people are not complying with these guidelines or protocols. We need to do things to improve compliance, and then we will solve our problem. And the obvious solution to improving compliance is to change behaviour. So we're looking at ways of, you know, how do we change behaviour? But what happens when we try to do that is we have a lot of difficulty changing behaviour. And so we've had a look at this, and we think that that really, if we have resilient thinking, there might be a little bit more to this story. So it might just not be a case of people not complying, as in deliberately not complying, and us just having to do some behaviour change. So if we look at it in terms of work as imagined and work as done, so people develop mental models of how work is done. And the further you are removed from the actual work as done, the less accurate your mental model is going to be. So in healthcare, we've got managers with a mental model of work as done in the clinical setting, which is more work as imagined, or how they would like it to be done in a perfect world. But because they are far removed, their mental model is actually quite different from the work as actually done by the clinicians. So the guidelines, as we were talking about earlier, are usually written for this work as imagined. And because those who write them usually aren't practicing clinicians. Most clinicians don't have time to go away and write protocols and guidelines. So the example I'm going to give you of looking at this difference between work imagined and work as done, and how to use FRAM to define that, is to do with an intensive care unit in a hospital in Australia. Now, we've done this work with intensive care units in Australia and also in Denmark at the moment, so we're starting to get a feel for what some countries have in common. So this particular problem was an ICU in Australia at a place called Townsville Hospital. It's quite a large hospital, 600 beds, and it's got 12 to 14 ICU beds. They're able to adjust the number. And the patients come into the ICU from the emergency department. They come in from the wards, so patients who deteriorate in the ward and require intensive unit care. And they also come in from surgery. And one of the main places they come in from surgery is from elective surgery. What we're finding in Australia at the moment, and we find this in many higher income countries, is as we have a more ageing population, the population that's coming into elective surgery has a lot more comorbidities or a lot more things wrong with them. And when they come into surgery, they can be much older. So 10 or 20 years ago, the average patient coming in for, you know, open heart surgery might have been in their 60s. Nowadays in Australia, the average patient is in their 80s, and some of them are in their 90s. So because a lot of these patients have these comorbidities and they're older, they normally have to have an intensive care unit bed booked for them before they do their operation, because they know that they're going to need some time in intensive care before they can go home. So in the Townsville Hospital, the usage of their ICU seemed very unpredictable. They couldn't predict who was going to come in from the emergency department. They weren't sure from surgery, so they didn't know what to do. And it was also highly variable. Some days they would only have a few beds occupied, and other days all the beds would be occupied and there'd be a queue of people trying to get in. And this was made worse by the fact that Townsville's in a remote area, so there weren't any alternate ICUs where they could send people to. So sometimes in a major city, if your ICU gets full, you can ship them to another hospital. So these guys didn't have that as an option. So what they did was they came up with a plan, so a protocol or a guideline of how they were going to manage this. So they decided that they would have 3 different codes for the ICU, green, amber and red, depending on how full it was and how critical things were. And they would, because they would allocated a code, they could then tell the surgeons ahead of time what the likelihood was of them being able to get a bed for their surgery patient. So what this meant was for the surgeons, instead of finding out at the last minute that there were no ICU beds available and having to cancel surgery, they would know a day ahead, and they would have a fairly good idea from a predictive viewpoint up to 2 days ahead. And the other side of it was they did something that isn't normally done in hospitals. The ICU offered something up. And what they offered to the surgeons was that if we're in code green and we know we've got lots of spare beds, you can do more surgeries. So the surgeons who get paid by the number of surgeries they do are pretty happy about this. So they could actually bring in a lot more patients than they would normally bring in, knowing that there was lots of spare capacity in the ICU. So the way we looked at this was the guys wanted, and the ICU wanted to implement this protocol in their ICU. So what we did was a thing called a FRAM of it. And what a FRAM is, it's a tool or technique that allows you to look at activities or events and the links between those events. So you can see a bunch of little hexagons on the screen there. And each hexagon has got an input and an output. And it also allows you to put in whether there's time that affects that activity, whether there's constraints that affect that activity or controls, whether there's resources that are required for that activity, and whether there's precursors or things that have to be done before that activity can be done. So this is the FRAM of the ICU protocol. So each of the little activities in the list is put into a little hexagon, and you can see they're coloured red, amber or green depending on which state of the ICU they relate to. So this is really useful because when you see a list of things, it's very hard to tell whether that's a practical list or not. Whereas when you have it in a form like this, you can immediately see, are there inputs and outputs for each of these activities? Or is one of them just hanging off by itself where nothing happens associated with it? Do all of the activities have appropriate resources? Are there any activities missing? And we found the first time we did this that the activity where the ICU would actually inform the surgeons that there was spare capacity wasn't in the protocol. So even though the intent was to let the surgeons know there were spare beds, it wasn't listed in the protocol. So we could see immediately there was something missing. And are all the precursors in place? So do things, if you follow the lines through, you know, is everything happening in the correct order, or do we find that something's happening that then blocks everything else up? The other thing about it too is you can see that some activities have a lot more connectors than other activities. And these are the activities that will be critical to whether the thing operates smoothly or not. So you can immediately see visually what are the critical activities in this particular plan or protocol that you might need to put extra attention towards when you go and implement it. So, and we found in this one, for example, that one of the activities in here was a meeting where they were looking at having a meeting every single day at the same time between surgery, the ICU and the bed planning staff. And they could see from this, because of the number of links, that it just was not a practical thing. So they're now looking at alternate ways of achieving that aim. So it's just an example for you. There's other tools and techniques coming out, but I thought we'd just give you an idea that there are things available to help you analyse.
And there's a website for this, so if you just Google Eric Holnagel and FRAM, you'll go to his website and you can download this software and play with it.
Yeah, and it's quite user-friendly. It's quite easy to use. So.
Yeah. And many people are starting to do FRAMs. There's even a conference where the Framily gets together and talks about FRAM-type studies that people are doing. And for me, I'm not a FRAM person necessarily, although I work with Eric and Bob Weirs and Richard Cook and Robyn a lot. But for me, this notion that you have, like the social network diagrams earlier, and this notion of having activities in this case rather than agents, and the connections between them is quite a useful way of seeing the world in its complexity rather than an organization structure which shows the hierarchy but not the complexity of how work gets done.
Yeah, and you can see just with the tool, like you can see some of these hexagons have got like red circle dots associated with them. It can show you immediately visually where there's a problem or where there might be a likely problem in your protocol.
So play with that if you wish, or this is just that you've come with us on this little journey this morning, my time, to just think about resilient healthcare and safety too. That's okay too. So let me try and bring this to a conclusion and finish up for you, and then we can take some questions. I think it's true to say that when we tell ourselves stories about safety, and the first story we tell ourselves whenever there's a breach of safety or something happens, we tell ourselves a story with linear thinking, with cause and effect logic. And we sort of say to ourselves, this happened, regardless of what it was, a mistake in surgery or someone getting an infection or someone getting wrong side surgery or a fall. This happened, therefore we should sort this out and do whatever, more training or a root cause analysis or whatever it might be, or tighten up the policy. So that's almost inevitably the first story we tell ourselves when things go wrong. Things have gone wrong, find out what happened, attribute the actions to people, uncover the root causes, and fix the systems so this doesn't happen again. How many times have we told ourselves that story? Countless. But you know, resilient healthcare suggests that almost no one comes to work to do a bad job. The same behaviours that occur to create good care are the behaviours that create care where it goes wrong. And that we really need to focus some of our attention on when things go right, even if it's to understand where we have our successes. But if it also uncovers where do we behave resiliently, where do we practice in a resilient way, and if we can learn from that, maybe we have a chance of affecting change in the 10% that go wrong by having a more positive message and effecting change that radiates across the system, rather than always myopically focusing on the 10% where things go wrong without much of that budging in terms of improvement. So linear thinking only takes you so far, and it kind of doesn't get you to healthcare itself, which really looks like this. The second story that we could tell ourselves when things go wrong and when things go right is that healthcare is much more complex than the first story. It's not linear at all. There are multiple interacting variables at work every time. And if we can uncover how come we did this behavior, this treatment, this protocol, this intervention, this care for patients, how come we did this many times previously and things went right, then we can learn from that. Incidentally, we might also send a more positive message to our clinical colleagues at the coalface, because I know we've always said to them we run a no-blaming system, but always focusing on when things go wrong does speak to them that we really are running a blaming system, a blaming patient safety initiative. If we were to say to them, hey, we've just noticed that 90% of what you do goes well, even under trying and difficult circumstances, and we'd like to work with you to understand that more and work with you to do even more things right and successfully, we've got a chance of bringing back in clinicians who I think we've lost along the way, along the last 20 years. So what we're advocating is that we have more productive insights into safety, that we generate from the second story we tell ourselves, the one that says what lies behind the first story about incidents and accidents and 10%. To not so much focus on when there's an inquiry and celebrated accidents, we'll do that anyway, and especially focus when there's a catastrophe or a blunder, because it's exciting for humans to do that, but also to look at a second story and say, where did we do well there? In the normal course of business, how come we radiated out, unfurled, unrolled care and got it right? With multiple interacting factors in complex systems, how can we do more of that? How can we combine our skills to produce systematic improvements to failure rather than always looking at the vulnerabilities. Because, you know, the system and the people in it, they manage risk all the time. Sometimes, of course, they fail. Sometimes errors go through to the 10%, but most of the time they don't. We really need to understand that. So resilience, and the second story, is a story of the system is resilient a lot of times. In fact, that's a property of systems. Most systems get most things right most of the time, but we don't focus on it. Resilience is the ability to remain intact and functional despite threats, adverse events that threaten the integrity and function of the care we're delivering. Resilience is the opposite of brittleness, when the system's just ready to fall apart and it's very fragile. And we think we need to focus a bit more on this idea of resilience. And as we say, we're publishing a series of books, and we have an annual meeting where people around the world congregate. So we'd like to attribute this talk, this webinar, to those people, the people who we're working with across the world, who are starting to think we need a different paradigm. We need to change the paradigm of patient safety and focus much more on resilient healthcare. So that concludes what we'd like to say, although, as you can tell from listening to us, we can talk about this a lot.
Much more to say.
It's a lot more than we've got books on this coming out, and lots of ideas and lots of papers. But we wanted to pause and give you the opportunity, if you wish, to maybe throw some questions or give us a reaction to what you've heard. So thank you very much, audience. It's been a pleasure working with you, Robyn, and working with you in the audience. So I think, Juliana, you're now back in charge, are you?
Yes, I am, for a moment only. Well, I would like to thank you for this exceptionally engaging, thought-provoking and impressive presentation. It's really inspiring discussion. We do have a couple of questions already, so I would suggest that we start cracking on them. And the first question is coming from Olugbenga Michael. His question stands as follows. In essence, does it mean that resilience in healthcare is celebrating what works even if it does not follow global standards, but give desired results?
That's a great question. I'll have the first go, but I'm sure Robyn might. So, you know, there's a big push on in various parts of the world for standardization, to reduce variation and to get everybody doing the same thing. I don't think that's my own view, and I think the resilient healthcare view is, I don't think that's actually achievable. I think we're spending a lot of effort trying to reduce variation in practice, in the way people treat patients. The reality is clinicians always have, do now, and always will vary in their clinical practice. I think it's more important for us to say some level of variability in a complex system is inevitable. You saw all those swirls of activity just to describe part of a health system. To try and say we're going to standardize that, that's crazy. Instead, what I want to know is, when natural variation in practice and care and treatment occurs, where is it where that natural variation gives you good care? Where is it when people provide good care? Yes, things go wrong sometimes, but where is it where we routinely deliver good care? There's another aspect of this, and the caller, the questioner, said about, is this about celebrating success? Yes and no. Sure, we should celebrate success. However, I'm not really worried about the 90% being a celebration of success. I want, as a researcher, to understand what makes it successful. I'll leave it to Ministers for Health to claim their system's world-class and successful. I'm not worried about that. What I'm worried about is, when does the health system, and how does it do it so often, deliver good care?
Okay, so firstly, I don't think we want to throw standardisation away. There are some aspects of healthcare that are very amenable to standardisation. The thing about it is to make sure that where we apply standardisation or regulation or any other linear process, that we're applying it to the right sorts of things. So for standardisation to work, it's got to be a fairly linear process. And what I mean by that is something that is able to be reproduced each time and to within a certain level. So And there are many healthcare processes like that. Like we know, for example, like setting central lines, that there is the ability to be able to actually standardise some aspects of that. But then there's other parts of healthcare where you've got the variability of the patient or the variability of the conditions where you're not able to do that. So rather than, like I wouldn't advocate getting rid of standardisation completely and just going for, well, if it works, that's great, let's get on with it. I think that standardisation does have a place, but we need to make sure that we apply it to things that are amenable to standardisation rather than things where it's just not going to work.
We're not going to get in a complex health system, right across the health system, the same standard of care delivered by the same standard of clinician, delivered in the same resource, exactly the same resource matching resource environment across rural and remote care and city care and in private and public. That sort of standardization, I would like the world to be different, but I don't think that's achievable.
But I mean, something like evidence-based care, like you can actually have, you know, a standard based on the evidence, but then you need to allow for a point at which you might depart from that in event that there's some variability there in the patient or condition that dictates that you depart from that. Yep. So it's really a matter of when you apply it rather than just applying it or not applying it. Yeah. I'm
just thinking we shouldn't give too long an answer because there might be other questions that Juliana has for us.
Thank you so much, Jeffrey and Robyn. Yes, indeed, we do have a lot of questions coming in. So, and the next question is from Lolita Mitevska. She's actually a fellowship participant from Macedonia. And her question is as follows. So, who follows the escalation plan? Is this the only part of this project, or is this a regular practice in Australia?
Oh, okay. I'll take that one. This is a very specific project associated with that intensive care unit, and I really just gave it as an example. I needed something fairly simple to give it as an example of where you could use FRAM. So it's only a very small part of a larger process, and at the moment it's only in one organisation.
Yeah.
Thank you so much, Robyn. The next.
We'll try and do short answers, Juliana. We'll try and do short answers.
Well, not too short, yes, but we do have a number of questions. And the next one is from Charles Payne. He's thanking you both for this inspiring presentation. And he's saying the ideas you have explained are the future of healthcare. Do you have some advice about how we build resilience into the patient care team at the clinical microsystem level?
Well, I'm going to speak with a bit of trepidation because Charles Payne is a world expert in this area and he's a very good colleague of ours. So I think he may be saying this tongue-in-cheek because I know his expertise is absolutely massive in this area. So, you know, clinical microsystems, the care delivered by clinical teams in and across departments and wards are the basic building blocks of healthcare. That's what we call the sharp end, the clinical front line. Building an idea in those teams that it's not, when things go wrong, and they inevitably will with every team, no matter how well functioning, diverting all their attention to just when the things go wrong, rather than also thinking, when is it that we deliver routinely good care, even against few resources, or you know, we don't work as well politically with each other than we should, or there's cultural problems or whatever, that we somehow manage to get good care delivered the majority of time. Trying to work within your own team and across nearby teams to understand how we do that so well and so often is a very good discipline for clinical microsystems and teams within them to have. So I would just have a simple answer saying, could all clinical teams, all clinical microsystems spend a bit of their brain power figuring out how come they get it right so often? What are the circumstances in which they succeed, rather than always waiting for the next error to occur and then that preoccupying them for ages?
We are starting to think, though, that the team is one of the key functions that improves or maintains resilience in healthcare. So the whole idea of having the multidisciplinary input and the team working together allows a greater degree of resilience to if you've just got a single person or if the team is not functioning well. So we think that teams is actually going to be part of our solution, but we're still researchers early on this. So,
yeah. And Robyn, in fact, your PhD, part of your PhD was on this, so your expertise in teams is very strong. Many in the audience would know that. Juliana.
Thank you, Jeffrey and Robyn. The next question is from Patricia McKernan, and she's from Canada. She's, again, like, we have an impressive feedback in connection to this presentation, and she is one of those who's thanking you for this most thought-provoking presentation. And her question is that, as a safety leader for many years, I'm considering how this thinking could be proactively applied. Would you suggest using the FROM technique in order proactively plan services and develop protocols and monitor the reliability of the system? If so, could this framework also be used to analyze when things go wrong?
Yeah, and it is being used for both. So traditionally it was developed for when things went wrong, to have a look at what the different activities were and how they linked together and where the problems occurred. But we're just finding that it's useful for translating a theoretical protocol to an actual practical one. So it's quite a good way, it's quite a good tool of putting the protocol or plan into a format that can be easily understood at the clinical level, and it's a good tool for then discussion of when you're going to implement that plan. So it's just one tool though. There's other tools out there. Like there's a thing called the resilience analysis grid that again Holnagel and colleagues have developed. That's another tool that gives you clues of how to maybe put proactive processes in place. So there are other tools as well. Just time didn't allow us to sort of go through all of them. Yeah.
Thank you, Robyn. The next question is a very actually interesting question from Elaine Mead. She's asking, how suspicious are your clinical colleagues of this approach when you observe how they get the things right most of the time?
Sorry, what was the question?
How suspicious are your clinical colleagues of this approach to observe
yes.
how they get things right most of the time?
If you come, look, we work with a lot of clinicians here and internationally, in Australia and internationally. If you come to clinicians and say, essentially, look, we're going to wait until an error occurs and then we need to come and talk to you. And then we need to maybe do a root cause analysis and find out what went wrong. You will naturally have suspicion. If you come to clinicians and say, look, we're going to do that because, there's a policy in place and we have to do that. But also what we'd really like to do is work with you to understand when things go right. And we'd like to really understand and appreciate the fine details of how you manage to get care successfully delivered so often. Then the barriers that get set up under Safety 1, where we're always looking to go and talk to people when there's an error, tend to dissolve. And people are much more interested. You know yourself, if somebody flatteringly says, I've noticed you're doing a good job, can I come and understand how good a job you're doing, and could you talk to me a little bit about that? You'd be much more receptive to meeting with that person and much more receptive to working with that person than if the only time they ever came to see you was when you stuffed up. Because all of us are going to stuff up sometimes. I know that's not a very technical term, Juliana, talking about stuffing up, but it captures the moment. So I think this might be, without being sickeningly telling people that they're always doing a good job. I don't mean that. I mean just trying to understand when things go right. I think that's a really big string to our bow. It's a very nice idea for us to talk and have a different kind of conversation with clinicians.
Yeah, great.
Thank you so much, Jeffrey. The next question, we do have a number of questions yet to go, and we'll be running out of time soon, so we will address as many as we can, and then we will deal with the rest of them after the presentation, if you don't mind.
Happy to.
Perfect. So the next question is from Claudine Shepherd, and she's thanking you for this impressive presentation. Her question stands as follows. Is resilience practice in a people blame healthcare system works? If not, how do you apply this principle in an environment prone to pointing blame onto the individual when things go wrong?
So Robyn might comment, but my immediate response is, it's taken us a long time to get to where we are in healthcare. It's taken us decades, even hundreds of years, And so the cultures and the way we do things are pretty rusted on. The cultures are pretty set in cement. This is a new paradigm. If it is a revolution, if it is a way of changing how we think of patient safety, and we think it is, then it's going to have to be a quiet revolution that takes place and radiates out over a number of years. We won't just be able to change things around, because you can't change a culture just on the turn of a dime. So if this is a cultural change, it's going to take some time, maybe 10, 15 years.
One thing we have found, though, is that in talking with clinicians and with hospitals and healthcare organisations, is that talking about how the system actually works rather than how they think it works, a lot of them really can grasp that quite quickly. It makes sense. It's a good fit with how people can actually see things happening in their workplace. And if they can understand how the system actually works, then they're much more likely to see what sorts of solutions will work as well. So understanding the complex nature of the system, people will be less likely to do the blame thing. But as Jeffrey said, it's certainly not instantaneous.
Thank you both. And the next question is from Tito Sektop from Ghana. He's asking, how suggesting that resilience delivers better patient outcomes than patient safety? In Ghana, the Ministry of Health keeps working on the standard operating procedures. Are you suggesting it's a waste of time?
No.
Yeah.
No. As I maybe said previously in answer to another question about standardisation, there's still place for procedures, there's still place for regulation, there's still place for standardisation. It's a matter of applying those to processes within the healthcare system that are the more linear processes and the processes that are amenable to that type of solution. So you know, as we said, evidence-based medicine, some of procedures and protocols. I mean, even things like root cause analysis in response to an adverse event will still yield some useful information, right? It's the idea, though, is just to not try to apply it to the areas where there is a lot of variability and there's a lot of complexity.
So my take on that is you don't want to stop Safety One activities, which is trying to raise the standards, find and fix errors, try and create better care that way, in the classic standard way we've been doing for 20 years. And in a developing system which may not have the standards or the systems in place, that's very important. So I would never stop Safety One activities. But I would say perhaps some of the time that we invest in safety could also be spent looking at where do things go right, where do we succeed under varying conditions, and how can we do more of that. So this is a complementary thing. We're not saying Safety 2 should usurp Safety One. We're saying we need a better balanced system.
Because that's how we got down to 10% of adverse events to start with.
Yeah.
Like, you know, by using these Safety One type processes, we've got rid of most of the problems, like the big ticket items. But now, addressing that other 10%, that's when we need to start looking at more resilient thinking.
Yeah.
Thank you both, Jeffrey and Robyn. We'll finish the Q&A session with this last question from Arola Zahara from Lebanon. She's thanking you for this new approach, but she has a question. How to bring together the differences between imagined work and work done when administrators are not on the front line and cannot experience field work?
Yes, that's a great question. And we're the third book in this series that we're summarizing for you, which hasn't come out yet. It won't come out until 2015 or even 2016, because these books take a long time to develop, is going to squarely address that issue of how do we align work as imagined and work as done. The quick answer is simple. We really do need better partnerships between clinicians on the front line and managers who often imagine how work is done but don't experience it because they're remote from the clinical coalface, and policymakers who are even more remote. We really do need them to be engaged with each other and working together. In some health systems they do things better than others in terms of engagement, but we need really teamwork at the policy, managerial, clinician and patient advocate groups level to try and say, we're all in this together. How do we all work concertedly to improve healthcare?
Yeah, I agree.
Thank you so much, Jeffrey. Just to remind everybody, we were going to wrap up this session for this morning or tonight. It depends whenever you are. Just to remind everybody that the recording of this webinar will be available on ISQua website within 24 hours from the live webinar taking place. So please pass the information to anybody who might benefit from the information in this webinar. I have a feeling we will hear more about it, especially at the ISQua conference, but that's for us to find out. Please also note that the fellowship program participants who attended the live webinar would be automatically able to claim 2 credit points for taking part in this activity. And for the participants who are going to view the recording of this webinar, they will have to answer the compulsory questions of the webinar to enable them to claim this credit point. Well, I would like to express huge thanks to both Professor Braithwaite and to Robyn for this absolutely engaging and impressive presentation. This really a thought-provoking a new area that we would like to hear more about it. And I would like to thank them for taking time today and delivering this presentation to us. I would like also to thank all of the attendees for being such a wonderful audience and asking so many questions. Thank you to all of you. Just the last thing that I would like to mention is that to improve the quality of our webinars, we would greatly appreciate if you can just fill in the post-webinar survey. It will take you no more than 1 or 2 minutes. Well, thank you. And I would probably like Professor Braithwaite and Robyn to say good day or good night to you and to say goodbye to you. And
yes.
I would not like to to leave them like that without saying goodbye to you. And once again, that will be a last thank you from me.
Thank you very much indeed. Thank you, Juliana, for organising this so well, and as you always do.
And thank you for the opportunity to present. Cheers.
Thank you to everybody.
Thank you.